Hey everyone, welcome back to the deep dive. Today, we're really going to get into something that affects millions globally, pneumonia. We're aiming for a comprehensive look. Diagnosis, severity, treatment, the whole picture. Our mission here is, well, to tackle some pretty detailed medical sources, stuff that can seem really complex, and break it down into clear, actionable insights for you. Think of it as a shortcut to getting well informed about a common but actually quite layered condition.
And it's so relevant, isn't it? Pneumonia is common, sure, but how it's managed is often much more nuanced than people think.
Yeah.
Understanding these details really gives you a fascinating look into medical decision-making.
Okay, let's unpack this then. What is pneumonia? Because, yeah, it's not just one single thing. There are different kinds, mostly based on where and when someone gets sick. So first up is community-acquired pneumonia, CAPP. That's when symptoms are diagnosed when someone first gets to the hospital. Basically, they caught it out in the community. The most common bacteria is Streptococcus pneumonia. And for viruses, it's met at pneumovirus. But interestingly, a lot of the time, doctors actually can't pinpoint the exact bug causing CAP.
Yeah, that's a key point. Despite our best efforts, the specific cause often remains unidentified.
Then you got the ones people get in healthcare settings. Hospital-acquired pneumonia, or HAA, that's when it starts 48 hours or more after someone's admitted. And similarly, ventilator-associated pneumonia, VAP, is when it develops 48 hours or more after someone's put on a ventilator, a breathing machine.
And those 48-hour time frames are really critical. They're not arbitrary numbers.
Right. Why is that?
Well, because if pneumonia develops after that point in a hospital setting, it signals that the cause might be different. We start thinking about bacteria that are more common in hospitals.
Yeah.
And crucially, these bugs are often more resistant to standard antibiotics. It changes the game.
Okay. So the environment really matters. So sticking with CIP for a moment, how is it actually diagnosed? You said it's more than just a cough.
Yeah, it's a specific combination. You need evidence on a lung image, like an X-ray or CT scan, showing what doctors call acute pulmonary infiltrates. Basically, something abnormal in the lungs.
Some kind of shadow or opacity.
Exactly.
Yeah.
Plus, you need at least one respiratory symptom and at least one other related symptom or finding. So the respiratory symptoms could be, a new cough or a cough that's getting worse, maybe bringing up more phlegm, dyspnea, that's difficulty breathing, or that sharp chest pain when you breathe in. And the other symptoms, things like crackles or wheezes the doctor hears, a fever over 100.4 F, high white blood cell counts, maybe low oxygen levels like an SpO2 below 90%.
What's really fascinating is how all these pieces fit together. It's like detective work, honestly. A cough alone could be anything. But a cough, plus that shadow on the X-ray, plus a fever. Now you've got a stronger case for pneumonia. It's this holistic view that's so important. Makes sense. So once it's diagnosed, the next step is severity, right? How serious is it? Exactly. And this is crucial because it guides treatment decisions. Doctors use major and minor criteria. Just one major criterion or three minor ones means the pneumonia is classified as severe.
And these criteria really separate the seriously ill from those who might be managed less intensively.
So the major criteria are the really serious ones: septic shock, where blood pressure plummets and needs medication support, or respiratory failure needing a ventilator. Pretty clear indicators of critical illness.
Definitely ICU territory.
Then the minor criteria. Still concerning, but maybe not immediately life-threatening on their own. Things like breathing really fast, say over 30 breaths a minute. Poor oxygenation, there's a measure called the PO2-FiO2 ratio.
Yeah, that tells us how efficiently the lungs are getting oxygen into the blood. A low ratio is bad news. It relates to ARDS criteria, too.
Right. Also, infiltrates in multiple lobes of the lungs seen on imaging, confusion, kidney function issues like a high BUN level, really low white blood cells or platelets, low body temperature, or low blood pressure that needs fluids.
It's quite a list, but each one points towards the body struggling significantly.
Okay, and here's where it gets really practical for deciding where to treat someone. The CURB 65 score.
Ah, yes, a very handy tool.
It helps decide if someone needs to be admitted to the hospital. A score of 2 or more generally means, yes, hospital admission, and CURB 65 stands for. C is confusion, U is uremia, that high BUN level we mentioned over 20, R is respiratory rate over 30, E is low blood pressure, systolic under 90 or diastolic under 60, and 65 is simply age 65 or older.
Simple to calculate at the bedside, right?
Uh-huh.
But it packs a lot of prognostic information.
So why are these specific criteria, both the severity ones and CURB 65, so vital?
Well, they directly answer the question, does this patient need to be in the hospital? And if so, do they need the ICU? If you meet major criteria like needing pressors for shock or ventilation, you're going to the ICU. If you have severe CAP by the minor criteria count or a high CRB 65 score, you're very likely getting admitted, maybe to a regular floor, maybe monitored more closely, maybe ICU depending on the specifics. It standardizes that critical decision.
Got it. Okay, so let's talk treatment. How is it tailored, starting with CAP? For someone who's generally healthy, no major chronic illnesses, and no big risk factors for nasty resistant bugs like MRSA or Pseudomonas, the options might be something like amoxicillin or doxycycline.
Pretty straightforward first-line choices.
Right, or a macrolide like azithromycin, but only if local resistance rates for strep pneumonia are low, like under 25%. That's an important caveat.
Yes, resistance patterns are key. You can't just assume an antibiotic will work everywhere.
Now, what if the patient does have other health issues? Comorbidities like heart disease, lung problems, diabetes, kidney issues, alcoholism, cancer, no spleen.
Then the approach changes. You need broader coverage.
Exactly. The recommendation is usually a combination. One beta-lactam antibiotic plus either a macrolide or doxycycline.
So maybe something like augmentin, which is amoxicillin clavulanate or cefpodoxim, paired with azithromycin or doxycycline.
Right, giving you coverage against a wider range of potential culprits.
And the guiding principle always is to try and narrow down the antibiotics once you know the specific bug. That's antibiotic stewardship. But initially, you often have to cover broadly. Also, there's a big push, rightly so, for oral antibiotics whenever possible. If a patient is clinically stable, they can often be treated effectively at home or switch from IV to pills sooner in the hospital.
What does clinically stable mean in this context?
Good question. It means things like temperature below 37.8 Celsius, heart rate under 100, breathing rate under 24, stable blood pressure above 90 systolic, good oxygen levels over 90% on room air, and importantly, they need to be able to actually swallow pills, have a working gut, and be mentally clear.
Makes sense. And how long does treatment usually last?
The standard is a minimum of 5 days. But treatment should continue until the patient's been fever-free for about 48 to 72 hours, and they have no more than one sign of that clinical instability we just talked about.
Okay. What about other treatments, like steroids?
Adjunctive corticosteroids. Yes, sometimes used, but only in very specific situations. They're powerful anti-inflammatories. So indications would be severe CAP that requires ICU admission, pneumonia related to COVID-19 if the patient is hospitalized and needs oxygen, or moderate to severe PJP, that's pneumocystis pneumonia, a fungal type often seen in immunocompromised people.
And the dosing would be specific, like hydrocortisone, methylprednisolone, or dexamethasone for COVID.
Exactly. Tailored protocols for each situation, not for your standard run-of-the-mill CAP.
And just quickly on a couple of specific CAP types, aspiration pneumonia, where someone might inhale something.
Right. The surprising thing here, based on current guidelines, is that you typically treat it with the standard CAP regimen. Specific coverage for anaerobes bacteria that don't need oxygen isn't routinely recommended anymore, which is a change from older practices.
Interesting. And if pneumonia is linked to the flu?
If someone's hospitalized with influenza-related pneumonia, definitely give them an anti-influenza drug like Tamiflu, regardless of how long they've been sick, in addition to the standard CAP antibiotics.
Okay, good to know. Now, let's pivot back to HAP and VAP hospital-acquired and ventilator-associated pneumonia.
The hospital-based infections, yeah.
We know they start 48 hours or more after admission or ventilation. You mentioned they often need a different approach because of different bugs and resistance.
Precisely. It's a different battlefield, often involving tougher organisms. So, the initial empiric treatment, what you start before you know the exact cause, has to account for that. For VAP specifically, everyone generally gets coverage for MSSA, the regular Staph aureus. But you only add MRSA coverage if there are risk factors, like recent IV antibiotics, or if MRSA is common in that specific ICU, say, more than 10-20% of staph isolates, or if you just don't know the local rate.
Okay. And what about Pseudomonas aeruginosa, another tricky one in hospitals?
Right. Everyone with VAP usually gets single coverage for Pseudomonas initially, but you use double coverage, 2 different antibiotics active against it if there's a high risk of multi-drug resistance, or if resistance rates in the unit are high for single drugs, or, again, if you don't know the local susceptibility patterns. Also, if the patient has structural lung disease like cystic fibrosis, you hit it hard up front.
And for HAP, the hospital-acquired kind not related to a ventilator. Similar principles.
Similar, yes, but slightly different thresholds sometimes. For MRSA coverage in HAP, you'd consider it if the patient had IV antibiotics in the last 90 days, if the unit prevalence is high, or if they're really sick, needing ventilator support or in septic shock.
And double Pseudomonas coverage for HAP?
Empirically, meaning before you know the bug, you'd consider double coverage mainly if they've had IV antibiotics recently or if they have that underlying structural lung disease. Once you know the pathogen, though, you tailor it. That's pathogen-directed therapy.
So if it is MRSA,
Then the go-to drugs are typically vancomycin or linezolid.
and if it's Pseudomonas and you have the susceptibility results.
Usually you can de-escalate to just one effective antibiotic based on the lab tests. The main exception is if the patient is still in septic shock or considered at very high risk of dying in that case. You might continue double coverage even if one drug looks like it should work, just for extra certainty.
How long does treatment typically last for HAP?
Generally, the target duration is 7 days for HAP, VAP specifically. Overall, therapy might sometimes extend, say, up to 15 days, depending on the bug and how the patient responds, but 7 days is a common goal now for uncomplicated cases.
Okay, so we've talked diagnosis, severity, strategies. Let's zoom in on the tools themselves. The antibiotics. It seems like understanding the different classes is key to understanding why certain drugs get picked.
Absolutely. It's not random. It's about knowing the strengths, weaknesses, and mechanisms of each drug class. It's fascinating, really.
Let's walk through some key ones. Maybe start with the macrolides, like azithromycin.
Sure. Macrolides, they work by binding to the bacterial ribosome, basically stopping the bacteria from making proteins it needs to survive. They're really good against those atypical bacteria that cause walking pneumonia, things without normal cell walls.
Like Mycoplasma or Legionella.
Exactly. And also common bugs like strep pneumo, side effects. Well,
Yeah.
GI upset is pretty common. And they can potentially affect the heart's rhythm, that QTC prolongation we mentioned.
Okay. How about tetracyclines, like doxycycline?
Similar mechanism, they also hit the ribosomes, stopping protein production. Doxycycline is quite broad. It covers atypicals, some community MRSA, and many common respiratory pathogens. A key side effect people should know about is photosensitivity makes you much more prone to sunburn. Good tip. And the fluoroquinolones, Cipro, Livaconir. Right, the fluoxetins. These work differently. They mess with the bacteria's DNA machinery, inhibiting enzymes called topoisomerases, so the bacteria can't replicate properly. Now, there's variation within the class. Ciprofloxacin, for example, is a powerhouse against gram-negatives, including Pseudomonas, but not great for gram-positives like strep pneumo. Moxifloxacin is kind of the opposite, better gram-positive coverage, less Pseudomonas activity. Levofloxacin sits somewhere in the middle, covers both reasonably well.
And side effects. I feel like these get talked about a lot.
They do. Potential for confusion, especially in older adults. That QTC prolongation again. Tendon rupture is a known, though rare, risk, the so-called black box warning. And like many broad-spectrum antibiotics, they increase the risk of C. difficile infection later on.
Okay. Let's move to the big beta-lactam family. Maybe start with the ones that don't usually cover Pseudomonas, like amoxicillin or ceftriaxone.
Right. These are workhorses. Their mechanism is classic. They inhibit the cross-linking of the bacterial cell wall, essentially making the wall unstable so the bacteria bursts. Great for strep pneumonia, a very common cause of CKP.
And you mentioned cefpodoxime earlier.
Yes, that's an oral cephalosporin, also a beta-lactam. It's sometimes used for CAP, particularly in patients with certain types of penicillin allergies, though true anaphylaxis needs careful consideration. Generally, these non-pseudomonal beta-lactams are very well tolerated.
Okay, now the beta-lactams that do cover Pseudomonas, like Zosyn or cefepime.
Yes, piperacillin tazobactam, Zosyn, and cefepime. Same cell wall mechanism, but they have a broader spectrum, crucially including good activity against Pseudomonas and other tough gram-negatives found in hospitals.
Any specific side effects to know?
They can increase seizure risk, especially in patients with kidney problems if the dose isn't adjusted. And cefepime, in particular, is associated with potential neurotoxicity, confusion, altered mental state.
And then there are the carbapenems, like meropenem.
The big guns, also beta-lactams hitting the cell wall. They are very broad spectrum, covering lots of gram-positives, gram-negatives, and anaerobes, often reserved for known or suspected multi-drug resistant infections.
But one doesn't cover Pseudomonas.
Right. Ortopinum is the exception, good coverage otherwise, but no reliable Pseudomonas activity. Like other powerful beta-lactams, carbapenems, especially imipenem, can also lower the seizure threshold.
Okay, switching gears a bit, vancomycin.
Vancdec. Cornerstone for gram-positive coverage, especially MRSA. It works differently from beta-lactams, inhibiting an earlier step in cell wall synthesis. It doesn't cover gram-negatives at all.
And the side effects. Kidneys.
Yes, nephrotoxicity is the main concern, requires monitoring of drug levels and kidney function. And that red man syndrome, flushing and itching during infusion, it's usually related to the infusion rate, not a true allergy, managed by slowing it down.
How about linezolid, also for MRSA?
Yes, linezolid is another excellent option for MRSA and other resistant gram-positives like VRE, vancomycin-resistant enterococcus. It inhibits protein synthesis like macrolides and tetracyclines. A big advantage is its excellent bioavailability, nearly 100% absorbed when taken orally.
Downsides.
It can cause myelosuppression, especially low platelet counts, thrombocytopenia, with longer use, so blood counts need monitoring. And there's a risk of serotonin syndrome if given with other serotonergic drugs like certain antidepressants. That's a potentially dangerous interaction.
Wow, lots to consider. What about aztreonam?
Aztreonam. It's unique. It's a beta-lactam, but structurally different. Its main niche is for patients with severe IgE-mediated penicillin allergies, like anaphylaxis, who need coverage for gram-negative bacteria, including Pseudomonas. It has no gram-positive activity.
So very specific use case.
Very specific.
Lastly, the aminoglycosides, gentamicin, tobramycin.
Generally used as add-on therapy for serious gram-negative infections. Or if other options aren't viable, they inhibit protein synthesis. But they come with significant potential toxicity.
Like what?
Reversible nephrotoxicity, kidney damage that can often recover after stopping the drug. But also irreversible ototoxicity, permanent hearing loss, or balance problems. That's a big one. And they're contraindicated in myasthenia gravis because they can worsen muscle weakness. Monitoring drug levels is crucial.
Wow, what an arsenal indeed, and each with its own job and potential pitfalls. This really highlights the precision needed, doesn't it? It's definitely not just picking any antibiotic off the shelf. So as we wrap up this deep dive, hopefully you feel like you've got a much clearer, more structured handle on pneumonia management. We've gone from defining the types to diagnosis, figuring out severity, the different treatment strategies, and finally digging into the antibiotics themselves.
Yeah, I think the key things to take away are just how vital that early, accurate diagnosis is, how nuanced assessing severity can be, the need for a really personalized treatment approach, and, well, the sheer amount of knowledge that goes into picking the right antibiotic from that huge toolbox we just discussed. It all has to work together.
Definitely. And maybe a final thought to leave you with. We live in an era where antibiotic resistance is a growing threat, a huge global challenge. How does this whole intricate process of diagnosing and treating pneumonia, this constant adaptation we've talked about, highlight just how crucial it is for medicine to keep evolving, to stay ahead of these superbugs? And maybe what responsibility does that place on all of us as informed people to really understand and respect these powerful medicines and make sure they're used wisely?